Okay, so this is basically unit 3. Okay, and again it's a part of chemotherapy, and a bit in this category is anti-tubercular agent. Okay, we have discussed yesterday antiviral agent. Okay, and this is anti-tubercular agent. So these are basically specific antimicrobial agent. Okay, others like chloramphenicol, penicillin, they are in general, okay, generalized chemotherapeutic agent, and these are specific chemotherapeutic agent. Okay, so the first of all, just briefly we'll try to see what is tuberculosis. Okay, basically this is a granulomatous disease. Okay, granules are formed. Okay, nodes are formed, granules are formed in the lungs, in the brain. Okay, so this is basically a granulomatous disease and it is chronic. Okay, it takes time to develop and takes time to for treatment. Then as far as epidemiology is concerned, so this is 1/3 of the world population is infected with mycobacterial tuberculosis. Okay, 1/3 of the population is affected by the tuberculosis. Okay, now you can see the need of the anti-TB drug. Okay, there is a demand of anti-TB drug worldwide. As far as India is concerned, so this is India is the highest contributor. Okay, in tuberculosis patient. So an estimate of 2010. Okay, this is as per the reports of 2010. So 2.3 million cases are there in India, and the death rate in India is 1,000 people die every day. Okay, because of the tuberculosis.
थर्ड फ्लोर तो पूरा खाली होता है, सीढ़ी में जाके बैठेंगे।
Okay, so 1,000 people die from tuberculosis every day in India. So now you can imagine the severity of the tuberculosis. Okay, just like in corona cases, in COVID cases, we are getting an estimate of death. Okay, like 5,500, 100. Who is this? 19 PS 68. Mute yourself. Okay, so now you can see the severity. Okay, in corona cases, we have variable numbers range from 100 to 10,000. So like this, tuberculosis patient, so the rate of mortality is 1,000 per day. Okay, in India, and it is going on. Okay, now we are having less number of COVID cases. Okay, or a less number of death in COVID cases, but in tuberculosis, this number is growing. It is not decreasing. Okay. Now see, the last point is India has a large load of HIV infected subject. Okay, HIV infected subject. So almost all HIV infected subjects are at risk of developing tuberculosis. Okay, almost all HIV infected subjects, they are at risk or they will have tuberculosis at some stage of their life. So because of these 2 points, we have a high number of HIV positive patient, and because of that, we are having high number of TB patient. Okay, I hope it is clear to you the severity of this disease in India and in worldwide. So as far as the drugs are concerned, now see, we have number of drugs, so we can classify that number of drugs into 2 category. One is first line category and another one is second line category. Okay, now see, the first line category, they have high anti-tubercular efficiency. Yes.
हेलो सर, सर
सर आपकी स्लाइड नहीं चेंज हो रही है
अभी?
यस सर
Okay, so see, as far as classification is concerned, so first line and then second line. Okay, now see, the first line, it is highly efficient, as at the same time it is having low toxicity. Okay, and the examples are like isoniazid, rifampicin. So you just go through the prescriptions of TB tuberculosis patient. So you will have these 2 drugs, isoniazid and rifampicin, and to some extent pyrazinamide also, ethambutol is also. Okay, so all these are the commonly used drugs in tuberculosis cases. Why? Because they are first line. And why they are first line? Because they are having high efficiency as well as low toxicity. Okay, so whenever you are studying the TB anti-TB drugs, so you should you should have to go through in detail all these 5 drugs. Okay, because they are first line as far as your exam is concerned. So the probability of question based on these 5 drugs are high. Okay, as compared to the second line drug. Okay, so try to study all these 5 drugs in detail for exam also, and for practical point of view also. You will find these drugs in prescriptions, in medical stores, in community pharmacy. So first line drugs are frequently used, so you should know what is the mechanism of action and what are the adverse drug reactions. Okay, and how you can tackle the adverse drug reaction आपको पता होना चाहिए एज ए फार्मासिस्ट. जैसे आपने एसोनियाजाइड दे दिया या डॉक्टर ने एसोनियाजाइड दे दिया, तो यू शुड बी एबल टू काउंसिल द पेशेंट कि इसके अंदर ये प्रॉब्लम होगा, जैसे न्यूराइटिस है. ओके, ब्रेन रिलेटेड प्रॉब्लम्स है, सो दे आर कॉमन. सो यू शुड बी इन अ पोजिशन टू काउंसिल द पेशेंट कि ये हो सकता है और हिपेटोटॉक्सिटी है. ओके, दिस इज रिवर्सिबल. So as far as the knowledge is concerned, so you should have knowledge, proper knowledge about the adverse drug reactions and drug to drug interaction. Okay, because see, nobody will ask you in common practice mechanism of action and all. Okay, but you should be able to justify the drug drug interaction and adverse drug reaction. Okay, so these are the 2 important points. Now come to the second line drug. Second line drug, they are low efficiency, they are having low efficiency and higher toxicity. Okay, and they are called as a reserve drug. Okay, they are the reserve drug after this option. Okay, once this option is over, then we will move to the reserve drug. Okay, so this is the drug like ethanomide. Okay, prothenomoid, cycloserine, tereziod, terizidone, then PAS, that is para-aminosalicylic acid. Again, fluoroquinolones. Okay, we have studied in detail fluoroquinolones, ofloxacin, leofloxacin, moxie, and ciprofloxacin. Okay, so here we will not go into the details of fluoroquinolones. Okay, but we can go into the detail of these drugs. Okay, because these are the important second line drugs. At the same time, we have injectables like kanamycin, amikacin. Okay, and another one is capreomycin. Okay, so you might have seen this drug in bacterial infection. It is commonly given, amikacin is commonly given as a parenteral injection. Okay, so this is all about classification. Okay, now come to the grouping of the treatment. See, we have 5 groupings, 1 to 5. Okay, okay, so group 1 is first line oral anti-TB drug. Group 2 is injectable anti-TB drug. Group 3 is fluoroquinolones. Group 4 is second line oral anti-TB drug. And group 5 is drug with unclear efficiency. Okay, now what are the characteristics? Group 1 is most potent and best tolerated. Okay, then group 2 is injectable. They are potent, they are bactericidal, but they are injectable. So if you want fast action, so you can directly go to group 2. Okay, if you have time, okay, if the infection is not that much severe, so you can go with group 1. Then come to the group 3. Group 3 is well tolerated. Okay, oral drug. All patient with drug resistant TB should receive 1 fluoroquinolones. So this is a reserve drug. You should use this in resistant cases. Okay, in resistant cases, right? So this is fluoroquinolones. Group 5, it is less effective. Okay, more toxic oral drug for resistant TB. Okay, if this option is over, then you can go to this lifeline. Okay, group 4, क्योंकि दोनों के अंदर क्या common है? Both can be used for the drug resistant cases, but this is more toxic. Okay, as compared to this one. The last one is Group 5 drugs are having uncertain efficiency, not recommended for MDR TB, multi-drug resistant TB, may be used extensively for in extensively resistant TB. Okay, see this is multi-drug TB, so this is more resistant. The extent or the uh, severity of the resistant development is high in this case. ओके तो जब बहुत ही ज्यादा रेजिस्टेंट हो जाएगा तो उस केस में वी कैन गो विद ग्रुप 5. okay, but in group 5 we are not certain, we are not having a surety about efficacy of the drug. Okay, but as a last option we can go with this drug. Okay, so these are the 5 main groupings of the anti-TB drugs. Now you can see there are several examples are given like isoniazid, rifampicin, pyrazinamide, ethambutol. Okay, this is almost all our first line drug. Then in this second line drugs are there like ethinomide, prothenomide, cycloserine, terizodine. Okay, pass. So these are second line. Then in injectable we have kanamycin, amikacin, capreomycin, fluoroquinolones, you know it. Okay, ofloxacin to sabko pata hoga. Okay, जैसे O2. Okay, O2 is a famous prescription. Okay, prescription drug for diarrhea. It is consisting of ofloxacin. Okay, so like that, all groups are having its drugs. Okay, 4 to 5 drugs are there in all groups. Yes, any confusion till this point? Yes, anybody? Roll number
No, sir.
29.
No, sir.
Okay. Roll number 55. Unmute yourself. Yes, 55. Roll number 70.
Yes, sir. 55, sir.
Okay. कुछ प्रॉब्लम है अभी तक?
No, sir.
Okay. Now we will move to the main drug, that is isoniazid. So this is a prototypic drug. Okay, main drug of anti-tuberculosis category. So the other name is isonicotinic acid hydrazide. Okay, see this is the basic ring and this is the group CONH-NH2 group. So this is basically tuberculocidal. This is not static, this is cidal. Okay, this is suitable for fast multiplying organism. Okay, fast multiplying organism के लिए इसको हम use कर सकते हैं. ठीक है, then it can act extracellular as well as intracellular. Okay, what is intracellular? The bacilli, the bacteria which is present within the macrophage. Okay, within the macrophage, अगर ये अंदर present है या बाहर present है, तो in both the cases, this antimicrobial agent can be active. Equally active in acidic and alkaline medium. Okay, so pH is not important for isoniazid. Now come to the main mechanism of action. It inhibits the synthesis of mycolic acid, which is a unique fatty acid component of mycobacterial cell wall. Okay, for example, this is your mycobacteria. Okay, so this is your cell wall. Okay, so this cell wall is consisting of a building block and this is your mycolic acid. So what this isoniazid is doing? Isoniazid is inhibiting the synthesis of this mycolic acid. तो जब ये बिल्डिंग ब्लॉक जो है माइकोलिक एसिड वही नहीं रहेगा तो ये सेल वॉल सिंथेसाइज नहीं होगा. ओके, एंड द बैक्टीरिया विल बी लाइक दिस विदाउट सेल वॉल, लाइक दिस. ओके, इमैच्योर सेल वॉल उसका डेवलप हो जाएगा और अल्टीमेटली इट विल बी किल्ड. ओके, so this is the mechanism of action. So in one line you can remember this, okay, this is inhibiting the synthesis of mycolic acid, okay, which is a part of mycobacterial cell wall. Okay, now see the other mechanism of actions. It is highly selective for mycobacteria. Okay, it is not active against any other microorganism. तो ये जो mycobacteria tuberculosis है, इसके लिए ही ये बहुत ज्यादा टॉक्सिक है. अदर माइक्रोऑर्गेनिज्म के लिए it is not that much toxic. It reduce the lipid content of the mycobacteria. Lipid content means जो cell wall है, तो उसका जो lipid content है, it is inhibiting the lipid content. Next one is it is targeting genes like INHA gene or Cas-A gene. These genes are important for mycolic acid synthesis. Okay, so it is inhibiting gene. Mycobacteria converts isoniazide to reactive metabolite by catalase peroxidase enzyme. Okay, try to understand this. Mycobacteria जैसे INH. Okay, INH, this is isoniazide. So this is converting to metabolite, reactive metabolite with the help of a enzyme. Okay, now this reactive metabolite is killing the bacteria. It is killing the bacteria. So this is the mechanism of action. So isoniazide is depending upon the enzyme for activity. Okay, then so just keep in mind this enzyme, role of this enzyme. Then this okay, then reactive metabolite, then this forms complex with NAD. Okay, ये जो metabolite है, this metabolite is forming complex with NAD, NAD. Okay, and this complex is inhibiting the gene. This complex is inhibiting the gene. Okay, this is the mechanism of action. On other side, this reactive metabolite, it is forming complex with the NADP. Okay, NADP. And this NADP is reducing DHFR. Okay, this is reducing DHFAR, and this DHFAR is interrupting or reducing the DNA synthesis. Okay, DNA synthesis. Okay, so this is what the mechanism is. It is inhibiting gene which is responsible for mycolic acid synthesis, and it is inhibiting DNA. Okay, which can be responsible for protein synthesis. Okay, so this is mechanism of action, a simple mechanism of action. INH is converting to reactive metabolite with the help of enzyme, and this is killing the mycobacteria. How? By forming complex with NAD and by forming complex with NADP. Okay, if it is forming complex with NAD, so it is reducing the gene, and this gene is responsible for synthesis of mycolic acid. Okay, तो यहाँ mycolic acid reduce हो जाएगा. Ultimately ये क्या हो जाएगा? There will be cidal action of the drug. On another side, NADP is forming complex with reactive metabolite, and then this is reducing DHFRA, and this is reducing DNA synthesis. See, this is an important slide. I want everyone to be very clear with this concept. Okay, now I'm giving 2 minutes. If you have any doubt, confusion, let me know. Yes, anybody? To ask question, you should listen it carefully first. Then only there will be a question. Yes, roll number 86. Are you there? 86.
Yes, sir.
Is that clear to you?
Yes, sir.
Okay. Okay, so I'm assuming that it is clear to all. Somebody is posting. Okay, DHFRA enzyme. Okay, see, dihydrofolate reductase. Okay, dihydrofolate reductase is an enzyme which is having a crucial role in DNA synthesis. Okay, so this is the answer of chat. Okay, now come to the resistance. Okay, development of resistance. Okay, as I told you, remember the role of enzyme, that is catalase peroxidase. So the bacteria develops mutation in catalase peroxidase. Okay, so that the reactive metabolite will not form. Okay, जैसे अगर मैं पीछे जाता हूँ यहाँ पर, okay, this enzyme, so this enzyme is not able to react with INH. तो जब ये एंजाइम इससे रिएक्ट नहीं होगा तो यही नहीं बनेगा, रिएक्टिव मेटाबोलाइट ही नहीं बनेगा. जब रिएक्टिव मेटाबोलाइट नहीं बनेगा तो ये आगे का पूरा एक्शन ही नहीं होगा आपका. तो एसोनियाजाइड इज यूजलेस नाउ. ओके, इट इज नॉट एबल टू रिएक्ट विथ एंजाइम टू फॉर्म रिएक्टिव मेटाबोलाइट. तो यहाँ पर एंजाइम के अंदर म्यूटेशन हो जाता है. ओके, सो दैट इज द फर्स्ट स्टेप ऑफ डेवलपमेंट ऑफ रेजिस्टेंस. सेकेंड स्टेप is mutation in INHA and Cas-A gene. Okay, this gene is responsible for synthesis of mycolic acid. ठीक है, यहाँ पर हमने क्या किया, यहाँ पर हमने एंजाइम को ही म्यूटेट कर दिया, तो INHA और Cas-A जीन फॉर्म ही नहीं होगा. ठीक है, अच्छा फॉर्म हो गया, once if it is formed then it will be muted. Okay, it will be muted and it will not be active. It will not synthesize the mycolic acid. तो अगर ये बन भी गया तो कोई काम का नहीं रहेगा because of the mutation. Then third mechanism is efflux of INH from bacterial cell. Okay, ये जैसे bacterial cell है, यहाँ पर INH है. Okay, तो this is pumping out of the cell. Okay, this is again a mechanism of resistance. Loss of active INH concentrating process means जैसे ये INH है, so it will not go inside the cell. Okay, this is also inhibited and this is encouraged. Okay, बाहर जाने वाली एक्टिविटी encourage होगी और अंदर आने वाली एक्टिविटी reduce हो जाएगी. Okay, so this is the mechanism of resistance. No cross resistance with other anti-tuberculous agent. Okay, जैसे हमने देखा था कि स्ट्रेप्टोमाइसिन से अगर रेजिस्टेंस हो रहा है तो क्लोरामफेनिकॉल से भी रेजिस्टेंस हो रहा है. ओके, बट यहाँ पर ऐसा नहीं होगा. यहाँ पर अगर एक से रेजिस्टेंट हो गया तो दूसरे से रेजिस्टेंस नहीं होगा. नो क्रॉस रेजिस्टेंस. ओके, नाउ कम टू द फार्माकोकाइनेटिक पैरामीटर्स. इट इज कंप्लीटली एब्सॉर्ब. यस, एनी क्वेश्चन ऑन दिस डेवलपमेंट ऑफ रेजिस्टेंस? जस्ट प्लीज लेट मी नो.
No, sir.
Okay, now see pharmacokinetic parameters. I'll go fast. Okay, because this is not that much important of that much importance. See, it is completely absorbed orally, penetrates all body tissues. Okay, even tubercular cavity, placenta, meninges. Okay, everywhere it will go and penetrate, right? Then extensively metabolite in liver, and the metabolism is N-acetylation by NAT2 enzyme. Okay, N-acetylation transferase. Okay, okay, so with the help of N-acetylation, it is converting into a metabolite. Then the acetylated metabolite is excreted in urine. Okay, now see, we have slow acetylators and fast acetylators. Okay, few people are fast acetylators. वो लोग क्या करेंगे, बहुत जल्दी इसका मेटाबॉलिज्म कर देंगे. बट few of us are slow acetylator. ओके, स्लोली क्या करेंगे, वो एसिटाइलेशन करेंगे. ठीक है, तो ये दो कैटेगरी के पेशेंट्स आर प्रेजेंट इन द पॉपुलेशन. सो इंड्यूस्ड पेरिफेरल न्यूराइटिस, ओके, इन्फ्लेमेशन ऑफ न्यूरॉन is common in slow acetylator. Okay, slow acetylator जो रहेंगे, in slow acetylator the metabolism is slow. Okay, तो इनके अंदर जो एक्टिव ड्रग है, हमारा एक्टिव जो ड्रग है, एक्टिव ड्रग का कॉन्सेंट्रेशन हाई रहेगा, एंड दिस कॉजेस न्यूराइटिस. Okay, a hepatotoxic minor metabolite is produced by CYP2EA from acetylhydrazine. So a hepatotoxic minor metabolite is also produced by metabolism. So this is pharmacokinetic parameter. In this you have to remember slow acetylator, fast acetylator. Okay, and peripheral neuritis. This is a common problem with the slow acetylators. Okay, adverse effect, as I told you, peripheral neuritis is the first problem. Okay, which can be like paresthesia. आपको जो है पिन पिन के जो चुभने का जो फील होता है ना, पेन, उस तरह से पेन होगा, नमनेस होगा, जैसे कि कूलिंग इफेक्ट रहता है ना, जिस आइस के ऊपर आप हाथ लगाते हो तो कैसे कूल हो जाता है हाथ. ओके, जैसे अगर आपका जो है एनेस्थेशिया अगर यूज करेंगे, लोकल एनेस्थेशिया, तो नमनेस आ जाता है. Okay, then mental disturbances, rare convulsions are also possible. Hepatitis is also possible. Hepatotoxicity is also possible, and other side effects are like lethargy, rashes, fever, acne, arthralgia. Okay, these are the common side effects. Out of this one, and this one. Okay, these three are important one. Okay, hepatitis is more common in older people and alcoholic. Okay, older people में क्या होगा, the liver is not fully developed, it is not efficient, मेटाबॉलिज्म का प्रॉब्लम रहेगा ओल्डर पीपल में. ओके, चिल्ड्रन में भी होता है बट इट इज रेयर इन चिल्ड्रन. ओके, और अल्कोहलिक्स में भी होता है बिकॉज अल्कोहलिक क्रोनिक अल्कोहलिज्म इंड्यूसेस CYP2EA एंजाइम which generate hepatotoxic metabolite. Okay, तो alcoholic are more prone to hepatitis if they are having tuberculosis with INH medication. Okay, I hope I'm clear with adverse drug effects. Now come to the next drug, that is rifampicin. Okay, see, rifampicin is a semi-synthetic derivative of rifamycin B. Okay, rifamycin B is a source which is obtained from Streptomyces mediaterrani. Okay, so this is the source of the rifampin. Then it is bactericidal to M. tuberculosis and many other gram-positive and gram-negative bacteria. It is bactericidal. Then against TB bacilli, it is efficient as INH. Okay, for anti-TB or for TB bacilli, mycobacterial tuberculi, this is as efficient as isoniazid, and okay, and it is better than all other drugs. Okay, M. tuberculi is highly sensitive, so it can be used in leprosy. Okay, it can be used in leprosy also. Then both extra and intracellular organisms are affected. As I told you in introduction to INH, INH is active in extra and intracellular organism. तो यहाँ पर भी अगर सेल के अंदर चला गया है बैक्टीरिया तो भी एक्टिव होगा, सेल के बाहर है तो भी एक्टिव रहेगा. Okay, rifampin. Then now come to the mechanism of action. It interrupts the RNA synthesis. Okay, it interrupts the RNA synthesis, as we all know that in protein synthesis there has to be development or conversion of DNA to RNA. Okay, and from RNA to protein synthesis. तो यहाँ पर क्या होता है ना कि RNA synthesis interrupt हो जाता है. How? By binding to mycobacterial DNA dependent RNA polymerase. Okay, RNA synthesis and RNA polymerase. So the name itself explaining it. RNA polymerase क्या करेगा? Polymer बनाएगा. Okay, RNA polymerase will form a polymer or chain of RNA. Okay, न्यूक्लियोटाइड का चेन बनाएगा और फाइनली एक RNA बन जाएगा. तो यहाँ पर क्या होता है ना कि RNA synthesis is stopped by action of rifampin on DNA dependent RNA polymerase. Now you can check the role of this in detail. Okay, what is the role of RNA polymerase in protein synthesis? At the same time, mammalian RNA polymerase is also present. Okay, यहाँ पर क्या है, माइकोबैक्टीरियल RNA polymerase है और एक दूसरा है mammalian RNA polymerase. तो यहाँ पर this RNA polymerase is not having affinity for rifampicin. ओके, रिफाम्पिसिन जो ड्रग है आपका वो इसी से अटैच होगा, इससे नहीं होगा. ओके, so that's why our human cell, our cells are not having any problem with the rifampicin. Okay, this is the important point. Selectivity, why it is selective for mycobacterial RNA polymerase only, why not for human? Because the affinity is high for mycobacterial RNA polymerase. Then rifampicin resistance is nearly always due to mutation in RPOB gene, reducing its affinity for the drug. Okay, तो यहाँ पर ये जो जीन है, this gene is present for this enzyme. Okay, तो ये एंजाइम के जीन के अंदर म्यूटेशन हो जाता है और फिर ये एंजाइम इज नॉट एबल टू रिएक्ट विद द रिफाम्पिसिन. ये जो अफिनिटी मैंने बताया ना यहाँ पर अफिनिटी, तो ये अफिनिटी चेंज हो जाती है बिकॉज ये आरएनए चेंज हो रहा है, आरएनए पॉलीमरेज चेंज हो रहा है. और व्हाई आरएनए पॉलीमरेज इज चेंजिंग? बिकॉज देयर इज म्यूटेशन इन जीन, आरपीओबी जीन. ओके, आई होप इट इज क्लियर. Yes, anyone? Any doubt? Yes, 20 dph 04. 20 dph 04.
Yes, sir.
Is that clear to you?
Yes, sir. Clear.
Okay. So again, no cross resistance is there. जैसे हमने वहां देखा था. Okay, तो यहाँ पर भी क्रॉस रेजिस्टेंस नहीं रहेगा. ओके, बट देखो वहां पर और यहाँ पर मैकेनिज्म ऑफ एक्शन थोड़ा सा अलग है. ओके, वहां पर क्या था, वहां पर माइकोलिक एसिड सिंथेसिस स्टॉप हो रहा था और बिकॉज ऑफ दैट सेल वॉल सिंथेसिस इनहिबिट हो रहा था. यहाँ पर आरएनए सिंथेसिस इनहिबिट हो रहा है. ओके, बाय म्यूटेशन इन आरपीओ जीन. Sorry, development of resistance is through mutation of RPO gene. Okay, now come to the pharmacokinetics. It is well absorbed orally, but you have to take it in empty stomach because food decreases absorption. Okay, then widely distributed in body, penetrate intracellularly, पूरे body के cavities के अंदर वो जाएगा, that is no issue. Then it can cross placenta. Then it is largely pump out of CNS by P glycoprotein. Okay, तो ये ब्रेन में तो जाएगा बट ब्रेन से पंप आउट भी हो जाएगा, CNS में जाएगा बट वहां से पंप आउट भी हो जाएगा. Then it is metabolized in liver to active deacetylated metabolite which is excreted in bile and urine. Then rifampicin and deacetylated derivative undergo hepatic circulation. Anyway, this is metabolism part and the T half is 2 to 5 hours. Then adverse effects are similar to INH, that is isoniazide. Then other uses are like leprosy. Okay, it can be used for meningococcal H influenza, meningitis and carrier state for prophylaxis. Okay, it can be used as a prophylaxis. Okay, majorly I can give example. If a person is HIV positive and he is on anti-HIV drug, so you have to simultaneously give anti-TB drug as a prophylaxis. As a prophylaxis, क्योंकि अगर उसका immunity down होता है at any point of time, so he is at risk of developing tuberculosis. So that's why prophylaxis treatment is given for that patient. Second and third choice of MRSA, diphtherios and Legionella infection. Okay, so all these are the infections. Okay, so this is a second line choice. Then combination of doxycycline, rifampicin is the first line of therapy for brucellosis. Again, this is an infection, so this combination is used with doxycycline. Okay, if you can see, this doxycycline was nowadays frequently used for respiratory tract infection. Miss Doctor has frequently prescribed it in last 1 or 2 years, doxycycline. Okay, so this is combined with rifampicin. Okay, so that's it for next session. We will continue with this and we'll try to finish the anti-TB drug. Okay, so without any delay, you start writing your roll number in chat box and simultaneously leave so that I can have an idea how many of you have written in the chat box.